Good afternoon, everyone. My name is Daniel Tudor Cosma. I'm an MD-SN CDE, and I work in Horezu City Hospital, Vâlcea County, Romania. Before starting my presentation, I would like to thank Ascensia company for giving me the opportunity to speak about a dearly subject and also to moderate this session at this wonderful congress. So my topic for today will be therapeutic education in diabetic food. Are we exploiting enough the online opportunities? So my presentation starts like a little history, and we know that a little history never kills nobody. It is well known that the food care problems were new from the ancient times, as you can see from this Eber's papyrus, which mention olive oil and cow fat as treatment for corns. And also from the ancient time, if you can visit Alexandria, you can see the oldest prosthetic in the world. It's called the Cairo toes, and is made from leather and wood device. And it seems like it was worn by 50 to 60-year-old woman. And as you can see, it's dated more than 1,664 years before Christ. When we are speaking about diabetes, the numbers are very concerning, as we can see from the last data published from the IDF Diabetes Atlas, the edition 2021. 1 in 11 adults in Europe has diabetes. What is the most concerning is the fact that 36% people are living with diabetes and are undiagnosed, and also that 1 in 7 live births are affected by gestational diabetes. Also, very important is that the European Union has the highest number of children and adolescents with type 1 diabetes, and it is a huge cost for the health insurance system. It seems like our region has the second highest average cost as after North America. We also know that the diabetic foot is a concept, and it reflects a severe chronic complication. And in people with diabetes, the amputation are 10 to 20 times more common compared to those of non-diabetic people. And it's a serious and costly complication. And it seems like the number of people with problems of their foot is increasing due to the increased prevalence of diabetes and increased life expectancy of these patients. If 15 or 20 years ago we spoke about an amputation performed every 30 seconds in people with diabetes, it seems like the latest data states that every 20 seconds an amputation is performed in people with diabetes, and this is also very concerning, being a burden on our social and also health insurance healthcare system. If we are speaking about the situation in Romania, this is a study performed by my mentor, Associate Professor Veresiu, who studied the number of amputation in people with diabetes between 2010 and 2015, and as you can see, a huge number of procedure of amputation were performed, and it was calculated that one amputation was made every 22 minutes in people with diabetes. We don't have other data for the period from 2015 up to these days, but the researchers are making an effort to have new data regarding this subject. Okay, so in front of this this problem, we have to take an action or we will pay. Why? Because many people consider that food problems, it's like atomic bomb for the healthcare and also for the insurance system. Why? Because as you can see from the study performed in the USA, the costs are huge and is increasing with the level of amputation. The same, the number of the hospitalization increasing. And what is very important important is that we don't have only direct costs related to amputation. We have also indirect costs. For example, people with different kind of amputation might need different modification in the house in order uh, to continue having a proper activities and manage their daily activities. If we are speaking about an amputation in people with diabetes, this has a huge impact on their life. For some people, this could lead to job loss or a retirement. If the amputation is bilateral, it means that that person might require 24-hour medical care. Usually, we need to change the treatment if the patient is on oral treatment. We may need to intensify that treatment, or we may need to change into insulin, and also increasing the cost, or newer agents like the GLP-1 or the SGLT2 inhibitors. Yes, of course, in this category of patient, we need prosthetic device, and usually in my country, these are obtained by personal funds of the patients. Also, very important are the psychological problem. We all know that patient with amputation develop all kind of anxiety or depression, and also problems more seriously, like suicidal ideation, and also accidental death, or provoke death. And also, what is very important is that the mortality in this patient are very high. We all know that from the study that a patient with amputation has a 50% chance of dying in the next 5 years. We have so many problems in these patients, but in these dark places and dark times, we all have a light, and we have hope, and this hope is represented by therapeutic patient and education. And what is that concept? So this education is managed by healthcare providers trained in the education of patient, and it is designed to enable a patient or a group of patient and families to manage their treatment in order to prevent complication while maintaining or improving quality of life. Its principal purpose is to produce a therapeutic effect. In addition to that, all other intervention, pharmacological, physical therapy, etc. And we know from the study that this therapeutical education actually works. As you can see here from the study, if patients were trained about managing diabetes and diabetic care education versus usual care, you can see clearly the benefits. If the patient follows an intensive course, 45 to 60 minutes in person, and after the course they receive written material, so they consult afterwards, it's the benefit, it's in favor of this intensive educational program. This therapeutical education, it's very complex, and there are some questions that we have to respond. Why we need therapeutical education? We need it in order to obtain the prevention of occurrence or progression of diabetic neuropathy, to realize the prevention of diabetic foot ulcer or amputation. And also very important, when to give this therapeutical education. And it seems like from the ADA guidelines that there are 4 critical times when we need to give this diabetes self-management education: at diagnosis, every year, when we are not obtaining the targets in our patient, for example, the blood sugar targets, the blood pressure targets, and so on, or whenever a complication appears, when a complication like diabetic neuropathy or diabetic retinopathy or an ulcer and other complication. And very important, who should be the person who offer this therapeutical education. We can speak about nurses or certified diabetes educator, the terms used in USA. The podiatrist can offer this education when he examined the patient, maybe the physiotherapist, also different kind of doctors, the diabetologist during the diabetic foot exam, the neurologist, or different kind of surgeons, for example, general surgeon, vascular surgeon, or orthopedic surgeon. And also very important is the fact that we can use also pharmacies, because we all know that people go very often in pharmacy, and in this time of the pandemic, the pharmacists can be a group of person that could really help our patient preventing diabetic foot ulcer. And how can we offer this therapeutical education? So there are different strategy, and also we can make this therapeutical education in person or using the online media. Yes, it is very clear that when we are using different strategy, we have to target some aspect of the diabetic care. We have to target the glycemic control, because it was proven that obtaining a good glycemic control, it will reduce the risk of diabetic neuropathy. It's very important to speak about lifestyle modification. Here we speak about medical nutrition therapy. We speak about diet counseling. We were speaking about management of the diabetes distress. All these things are meant to reduce the risk of diabetic neuropathy, to prevent the progression, and to also to reduce the cardiometabolic factors. But it is very hard to do this, because as you can see, the availability of this service is low, especially in countryside environment. The long-term behavior change is challenging. We need to invest in this structure who offer this kind of lifestyle modification, but definitely in time we will obtain a decrease in diabetic neuropathy and diabetic foot ulcer. Also, we have to offer education regarding foot care, because it was shown that this thing reduced the risk of further foot complication. And we need to have special multidisciplinary foot care service, but often it seems like this service underperform. And we also know from our practice that the patient compliance with self-foot care is often low. We often advise our patient that you need to wear a special shoes every time you get out of the bed, but this thing never happens. And usually they wear this kind of shoes only 40 up to 60% of the time. And also, many times they have to buy these special shoes from their own economies, and it is very hard, especially in this economical crisis. When we are speaking about the online opportunity, also we have to recognize that the online media is also a dangerous land, because people get all kinds of information from Facebook or different social media, or from Google, and many times they are not getting accurate information regarding diabetic foot care. As you can see, the offering virtual counseling produce an important decline in limb amputation rate. This is the situation in North Devon. It's a region in UK. As you can see, the number of the limb amputation declines in this region from 2014 up to 2018. What is very important is that the average average length of admission in hospital for the patient, it's the lowest compared to other region in UK. And it seems like, despite the fact that the prevalence of diabetes in this region has increased from 7.1 to 7.5, emergency admission into hospital for people with diabetes has reduced with 3%, and the major amputation had dropped by 77% compared to 0.8 in other parts of England. And due to this online education, it was an increase in referral to podiatrists, but despite its increase, the average weight was reduced by 10%. So this is a very good study that shows us that online education regarding diabetic foot care really works. I was speaking about the materials that our patient can find on the internet, and in this evaluation, we can see that most of the materials, the educational materials, are very hard to read for our patient and is not easily for them to understand according to this Flash Kincaid reading ease, or this Flash Kincaid grade level. So we need to develop materials, specific materials regarding foot care that are easily to read and easily to understand by our patient, and we must disseminate it on all the channels. As you can see, the academic institution have the highest Flash Kincaid reading scale, but regarding the grade level, it's one of the lowest. So we are offering good information to our patient, but our patient cannot easily understand it. So this is an important issues. In this article, it was well stated what are the most important information that we need to deliver to our patient during the therapeutic education. And as you can see, the most important is to perform a daily foot examination, especially in patients that are higher risk. For example, the patient who are smokers, who are diagnosed with peripheral arterial disease, with loss of protective sensation. It's very important to wash their feet with water and soap without exceeding 5 minutes. They should not use excessively hot water for foot washing. The importance of using a cream for moisturizing the skin, and very important, never walk barefoot or without sock, even in the house. They should wear proper shoes, and they should avoid flat shoes or very high heels. It's very important that they go to podiatrist and renew shoes periodically, and every time they have like a problem like hyperkeratosis or ingrown nails, they must be seen by a specialist, a podiatrist or dermatologist or a surgeon. They have to cut their nails straight. They have to take care of bed sheets, not to create pressure on the feet. They should raise feet if you sit for a long time, to promoting circulation. And the last advice are regarding the general recommendation in people with diabetes to control the glycemic label, to avoid alcohol, tobacco, to exercise daily, and to have a healthy, balanced diet. And every time there is a problem in the food, especially redness, swelling, or injury, they should go straightly to a specialist, family physician, diabetologist, or podiatrist, because there could be a problem, for example, a Charcot foot or osteomyelitis. To resume this concept of therapeutic education and the online part of this therapeutic education, this this it's the plus are that there are written materials, images or videos, and we can disseminate on multiple websites and social media. It's addressing to individuals or larger groups. It can be accessed when needed, and it was proven that is efficient, as previously shown in that study in Devon region in non-pandemic condition, and very important during the COVID pandemic. This is the only possibility to do this kind of education in many cases. What are the, let's say, the disadvantage is that it's not easy to distribute the information on multiple channels. It's a problem with source recognition, requires that patient has the digital competency. They need to have a phone or a laptop, access to internet. They need to be able to search on the internet the proper information. And also very important is that this online therapeutical education for diabetic foot needs to provide information of interest for this kind of patients. Yes, it's a battle, let's say, to offer our patient the best education, and we are like a little, let's say, like little heroes. Let's say we can make a difference in our patients regarding decreasing the incidence of diabetic neuropathy and diabetic foot. But every hero needs a team, and we can make a very good team with professional societies. For example, this is an initiative of the Society of Diabetic Neuropathy from Romania, and it was with the support of a medical company, Vorvac Pharma, in which we are trying to disseminate the Michigan test is the Michigan symptom score. The patient just go on the internet, and he he responds to 15 questions, and he obtain a score. And with that score, he can go to family physician, to his diabetologist, or podiatrist, and he can see, the specialist can see that he has a problem, and it's a diagnosis. It may have diabetic neuropathy, and they need to be further investigated in this direction, because we know that the diabetic neuropathy is the main component in the triad of diabetic foot ulcer formation. Also, a very nice campaign in Romania, which was recently started, is this Stand Up for Your Feet campaign. It's a campaign that designated for our patients, for family physicians, for specialists, and also it was designed for pharmacists, because as I stated a few minutes ago, our patient have a good collaboration with pharmacies. They go in pharmacies for every problem, not only to take chronic medication. If you have a headache, if you need to buy some creams for foot care, and so on, and involving a lot of professional healthcare in this category of patient, in treating our patient, could improve their knowledge regarding diabetic neuropathy and diabetic foot care, and obtaining a decrease in ulceration and also amputation. I want to finish my presentation by this conclusion that structure and mostly important repeated therapeutical personal education, including online, has the potential to reduce the burden of diabetic neuropathy and to prevent amputation. And with my last slide, I want to thank you. This is a representation of Horezu Ceramics, which is specifically to the city where I work and live. And if you have the opportunity to visit this region and to see this wonderful ceramics, I wait you there dearly. Thank you so much.